Okay, hello everyone. And a big thanks for inviting me to come speak about a topic that I've spent a fair amount of time working on and really enjoy. And so we're going to talk about what I think is the most challenging aspect of cardiac MRI, possibly of MRI in general, and that's trying to image the fetus. And usually the first thought is why? Why do this with MRI? I think everyone just associates imaging the fetus with ultrasound. It's pretty much available everywhere. It's safe. And it's really good at looking at the morphology, the function, the flow, the things that we care about when we're trying to detect disease really at its earliest stages. And so this plays a huge role in how we screen, monitor treatments, which is a growing number of potential treatments during pregnancy, and ultimately inform the timing of delivery and then what level of pre or postnatal care is needed. And this, of course, plays a big role if you're the parent on the other side and want to know what's happening in cases where they suspect disease. Imaging is really important for this. Now, having said that, in the last sort of 15, 20 years, there's been a really growing role of MRI to complement ultrasound. And this is primarily in cases where ultrasound can be difficult. So in the later stages of pregnancy, you have more artifact from bone, or you might have that throughout pregnancy, depending on the anatomy of the mother. But in addition to that, in addition to just helping in those difficult cases, there's also things that MRI can do that ultrasound can't. So it really, in terms of the way that we evaluate blood flow, it's quite unique how we can do it with MRI, and also looking into things like tissue characterization. This may lead to really some unique biomarkers that we can do in MRI, but not with other modalities. But as you can imagine, this is a really difficult thing to do, as I alluded to before. So we're dealing with a heart rate that's faster, almost double or more than that of what we usually deal with in both pediatric and adult populations. The scale that we're looking at in terms of what we need for spatial resolution is, of course, much smaller. And then, as we've talked a lot about already this morning, we associate adult and pediatric cardiology with having an ECG to trigger these sequences. And while we have lots of different ways of doing this, sort of 15 years ago, this really wasn't something that would allow us to image the fetal heart. That has changed, and we'll talk about why in the upcoming slides. And then, of course, the most difficult challenge is the most uncooperative patient that I think you can have. Because even in an uncooperative child or adult, you can at least at some point tell them to stop or sedate them, which is generally speaking not something we do in fetal cardiac MRI. It is done sometimes, but in most cases not. And so in the slides this morning, what I really want to talk about is sort of this journey where we've gone from sort of 15 years ago to where we are today, going from sort of two-dimensional static images that were at least remarkable in that they gave us a basic sense of the anatomy with MRI to now getting closer and closer to what we have in adult cardiology, which is big volumetric reconstructions that look at function, anatomy, and flow. And throughout it, I'll try and just give you a basic sense without going into all the technical details of sort of how we do this in terms of the sequences we use, where you might have additional hardware to enable this, and then the different research softwares and tools that have allowed us to really turn this into something that's state of the art. And so, as I said, the beginning of this journey was really just doing the standard Cartesian 2D sequences as fast as we could, and then seeing what we could see. So hoping the fetus doesn't move, hoping that the cardiac motion, while it blurs the structure, isn't that challenging. And this was really nice to show sort of the initial utility of cardiac MRI for imaging the fetus. But then when we wanted to actually start looking at the dynamics of the cardiac anatomy, we had to come up with a way of synchronizing our acquisition. So no possibility of ECG. A lot of the self-gating methods were still sort of in their infancy. And so this was something we developed in Toronto, which is sort of a type of self-gating method that allowed us to get the cardiac motion out of the data and then do either cine anatomy and imaging or cine 2D blood flow. And what was nice about this is we were still using sort of widely available sequences on the scanner, and we had sort of research software to get the cardiac signals out. And in parallel to this, another thing that was being developed was these early tissue characterization methods. And so this is something that was really led by the group in Toronto. And what you're seeing here, not all the details are super important, but basically you're doing T1 and T2 maps and then correlating this with oxygen saturation. And the important thing to note is that on the left here, we have sort of counterintuitively higher oxygen saturation in the right side of the heart than you do in the left. And this is because there was a restrictive atrial septum here. So usually in fetal life, you have blood flowing between the atria. And this is basically because you're bypassing the lungs. So the oxygenated blood's coming from the placenta, umbilical vein, up through the right atrium into the left side, and then pumped throughout the body. And so they performed a surgery in utero, and then they could show that not only has the flow value gone up, so that's the numbers here in the white circles, but we start to get a balance of the oxygen saturation as well. So you can imagine how useful this could be in cases where you're monitoring in utero treatments and really something that's specific to MRI. Then moving forward, in addition to or in parallel to the software methods that allowed us to image the dynamics of the fetal heart for the first time, there's this group in Germany that developed this gating device. So it's basically an ultrasound, a Doppler signal that you can use in the MRI environment. And then this really takes the place of the ECG and allows you to use standard sequences to get dynamic images. And this has been really useful in then showing, how we can use these standard sequences to again affect clinical decision making. And so, in these slides shared with me from Eric Hedstrom at Lund University, these are basically two cases where there was conflicting information between the ultrasound and the MRI. So the important thing being that in each case, in the left-sided case, the assessment of the aorta was normal, but the MRI seemed to show a narrowing. And then the right-sided case, they thought there was a narrowing of the aorta in ultrasound, but it turned out being completely normal in MRI. And in each case, the postnatal diagnosis was agreed with the MRI and not with the ultrasound. So, and in both of these cases, these were really instances where shadowing was preventing the ultrasound from really seeing the anatomy that we were interested in. So then in sort of 2016 to 2018, there was a lot of groups that became interested in this type of work and started to really push the boundaries of what we could do. So moving away from these standard MRI sequences that exist on our scanners and implementing all of the wonderful things that Matthias talked about this morning, self-gating, compressed sensing, including some pioneering work by Jérôme Chaptinel from our group in Lausanne, that really allowed us to now start to get higher spatial resolution, higher temporal resolution, and do this all in faster scan times. And the faster scan time is important, not only because it allows us to be less susceptible to fetal motion, but allows us to get more slices, more coverage of the heart. And so if you then look at this example, now if you really think of that first two-dimensional imaging, static imaging, now we're going to dynamic imaging in multiple slices, and you can really track the anatomy in a similar way that you would with a really good ultrasound sweep. And so in this case, really going through being able to identify the morphological left and right ventricle and connect that all the way through up to the vessels that connect to the head and neck, and make a diagnosis based off these really beautiful images. Similarly, in this case here, we have a case where there's a really large fetal mass that an ultrasound they suspected was completely blocking the left ventricular outflow tract. And it wasn't until we did this MRI, and again, we're able to sort of follow the anatomy dynamically throughout these slices where they could get the correct diagnosis. And so each of these last two are using now sort of state-of-the-art research sequences, as well as software developed by researchers. And this has been really useful when it works, which is always the case with cardiac MRI. And so if you look here, you have these initial images on the top that were very blurry due to cardiac motion. If we throw everything that we can at them, we get really nice high-resolution images where we can correct the motion. The problem, though, is that if you think of the heart that we initially tried to image, we prescribed these 2D slices. The individual slices we got out are very nice, but they are not at all in the order that we wanted them to be in to really track the anatomy. And this really shows the unmet need of 3D. So if you think back to Matthias this morning explaining how hard it is to plan all of these different slices, and we'd rather do this in 3D, it's doubly so here, where you can plan all these slices and not even have them where you need them to be. And so this has really motivated a couple different approaches. The first one from the group at King's College really builds on something that was initially done for the fetal brain imaging. And the idea here is you still do 2D imaging, but you do it in many orientations over many different slices. And then after you reconstruct those motion-corrected images, you can put them back together and interpolate into sort of a contiguous 3D volume. So despite having so much motion corruption in the initial images, you can get these really nice 3D renderings. And this has been extended from 3D imaging, showing really nice correlation with postnatal CT, and then even turned into something that can do something that's kind of akin to what we get with 4D flow in pediatric and adult MRI. This was further improved upon by the group in Toronto, going back again and moving to really high resolution research sequences. And what's really interesting in this work is they've been able to show, really for the first time, non-invasively in humans, basically the real key characteristics of the fetal circulation. So if you think back to those oxygen saturation images I showed earlier, where I was talking about the circulation and its differences, and that the oxygenated blood is coming up through the umbilical vein and then being shunted from the right atrium to the left atrium. This is something they could observe now in humans and characterize in a way that was really only done in animal experiments before this. And then again, taking the same approach, taking many of these 2D images with a high resolution sequence, they can do really nice cine anatomical images as well. So again, in parallel to this, if we go back to the hardware device that exists for cardiac gating, you can also take your MRI sequences that you already have on the scanner for 3D and attempt to do some fetal imaging with this as well. And this is very nice work from the group in Hamburg. There's a group in Colorado that's done this as well, where they've applied 4D flow imaging to the fetus. And assuming there's not too much motion and you can get the scan done quick enough, you can have these really nice 4D flow visualizations and some quantification of blood flow in the vessels. But again, ultimately, what we want to do is have something that's 3D, that's motion tolerant as well. And this is some work from a group in Lund that's applying a sequence very similar to what Matthias was showing earlier, this 3D radial sequence that allows us to get whole heart coverage with isotropic resolution. And here they showed the first results where they compared 2D and a 3D sequence, not yet with any type of motion correction, but with the ultrasound gating device providing them dynamic images of the heart. And then this entire talk is really just to hype up this last slide, which Robin will be talking about in much more detail this afternoon. But this is where we are at now with the work that I'm leading with Robin in Lausanne, where we're trying to take everything we've learned, all of those different pieces of the free running engine that Matthias talked about, and then take this back and apply it in a really challenging case where we're dealing with tracking the motion of the fetus in 3D, correcting it, having dynamic images, and doing this so that we can retrospectively, as you're seeing here, go through the cardiac anatomy, beginning with our 3 planes of axial, sagittal, and coronal images, and retrospectively be able to change the scan plane really arbitrarily and track the anatomy in a way that just really wasn't possible with the 2D methods that existed before it. And so to summarize, I hope I've convinced you why MRI can be exciting and useful for imaging the fetus. Ultimately, like I said, it's here to complement ultrasound, so cases where it's difficult, but also provide some new information, some different information, all with the goal of improving patient management. And you can do this with standard sequences that you already have on your scanner. You can do just 2D imaging, and this can still be very useful depending on the patient and the circumstances. With advents in hardware like this ultrasound device, you can take that into dynamic imaging as well. And then if you reach out to us or any of these other groups that have been pushing the software side of it in terms of coming up with new specialized sequences and reconstruction platforms, this really allows you to deal with motion, get images that are three-dimensional, and allows you to really do these really nice images. And then lastly, I just wanted to highlight here sort of, this was an image we acquired really early on during my master's in Toronto. And we were very excited about this because it was a fetal heart that was beating with cardiac MRI, but relatively low spatial resolution, temporal resolution, and what we thought was a pretty fast sequence, but we were limited. And then this was towards the end of my PhD, still in Toronto, where we really had very nice resolution. We were able to track and correct for the bulk motion, as well as the cardiac and respiration, get really high temporal resolution, and all of this without actually changing the scan time at all. And so it's come a long way. There's, I think, quite a bit more to do. And as Matthias said, it's the gift that keeps on giving. There's more challenges, more parameters to tune. But with that, I'd like to thank you all for listening. Thanks to those that provided me with slides on this topic, and welcome any questions.